Yeah, all right. So we'll be in two sessions. Initially, I wanted us to have the lecture on Wednesday, but I figured it might be an overload on Wednesday. So I thought maybe we can use 30 to 45 minutes to discuss DVT. And then on Wednesday, God willing, we use like probably 30 to 45 minutes to discuss PE as well, so that we can have like some time to ask questions. Otherwise, it will be a bit of a rush if we are trying to use 1 hour to complete both topics. Okay. I mean, they are linked. That's why we got them in one slide, but we'll just try and then finish DVT today. And then hopefully if there's time on Wednesday, we can just do PE. It's a short topic, so shouldn't be so difficult. So outline for today, I mean, we'll be going according to what we have in the slides. So we'll just talk a little bit, about DVT definition, and then basically what it is and how do you develop a thrombus or a clot in the deep veins. We'll look at some risk factors. And then when you are sitting in the emergency room and then a patient comes in, or you are sitting in the OPD and a patient comes in with complaints, what are you going to look out for to help you make your diagnosis of DVT? And also we'll look at some investigations, okay, when it comes to trying to make a diagnosis of DVT, and then we'll manage as well. So it shouldn't be so stressful. So as the name suggests, we are looking at the deep veins, basically. So if you remember your anatomy, we have the superficial veins and then we have the deep veins. When we are talking about deep venous thrombosis, the focus is now on the deep veins, okay? And the human body has deep veins all over. So one thing we should know is that deep venous thrombosis is not only related just to the deep veins of the lower limbs. Thing is, that is the commonest site where we usually tend to find it, but you can have a thrombus forming in the deep vein of even the abdomen, okay? So it's not just about the deep veins of the lower limbs. So when you take a look at the slides, you realize that you can also have a thrombus forming in the deep veins of the upper limbs. You can have a thrombus forming in the brain as well. And then in the abdomen, the vessels going to the gastrointestinal system. You can have a thrombus forming there as well. Now the question is, what is a thrombus? So I'm sure we've all done a little bit of pathology. Let's just bring it to the layman's term. We are talking about a clot, okay? And I always say that for a thrombus to form, you should have some things happening in the system, okay? Or there should be a baseline or some sort of activity happening in the system to predispose and precipitate the formation of the thrombus. So if a thrombus is a clot, and question is, when do we get clots? So we get clots when you sort of develop some sort of injury. So when you develop an injury, the clotting cascade will be set in motion. And once it's set in motion, you form a clot to sort of seal off the bleeding, okay? So once we are looking at thrombosis or a formation of thrombus in the deep vein, then that's what we are looking at. There's usually some form of damage there. And then this damage would lead to some sort of bleeding. And to stop the bleeding, the body will activate the coagulation cascade. And once the coagulation cascade is activated, it comes in, forms a clot, and then seals off the bleeding. Okay. But what happens is that in the case of a thrombus formation, when you look at the actual pathology of the thrombus, you realize that once the platelets and all that is activated to come and stop the bleeding, the platelets, they tend to be very sticky, so they trap red blood cells as well. And once the red blood cells are trapped, it's like there's still some form of injury going on. Your body still feels there's some injury going on. So you have another layer of proteins lining over the red blood cell. This sticky platelets would also attach itself to more red blood cells. In the end, you have a layer of platelets on top of that, red blood cells, then platelets, and then red blood cells. Okay. And once this forms, this is basically a clot. And most of the time, this clot that has been formed, or this thrombus, tends to be unstable. So even though it's attached to the inner lining of your blood vessel, and in this case, the veins, it can actually break off easily and then move into circulation. Okay. And once it moves into circulation, you tend to have the systemic effect of the clot. Ideally, if the clot or the thrombus is just at the site of formation and it hasn't moved into circulation, what you have is a local effect of this clot that has been formed. But as soon as the clot breaks off and goes into circulation, you start having a systemic effect of the clot. And we'll be discussing that in the second part of our discussion, hopefully in 2 to 3 days' time. Okay. All right. So now the question is, I'm sure one may ask, what is a thrombus and what is an embolus and what is the difference? Okay, because most of the time, apart from the fact that you hear people talking about a thrombus, another word you hear people talk about is an embolus. Okay, so basically an embolus is a thrombus that has found itself in circulation. So if the clot forms and is attached to the inner layer of the red blood and the blood vessel, is termed as a thrombus. Once the clot breaks off the inner layer of the blood vessel and it gets into circulation, the name changes into what? An embolus. Okay. So embolus is basically a thrombus floating or flowing in circulation. Now, the main thing here we'll be looking at is the pathophysiology. And once you understand the pathophysiology, it makes everything. There's something called the Beckhoff's Triad. Okay, the Beckhoff's Triad. And this Beckhoff's Triad basically explains how a clot is formed. So the formation of the clot is all based on the Beckhoff's Triad. Once you understand the Beckhoff's Triad, every patient that sits in front of you, every patient that you assess, you'd have an idea whether you should consider a possible DVT in this patient, or you should even consider making a diagnosis of DVT there and there in this patient, okay? Because the Beckhoff's Triad, which gives us a pathophysiology of DVT, also gives us an idea of the risk factors that you would expect in a patient likely to get DVT. Looking at the Beckhoff's Triad, you realize that I wrote 3 main things: stasis, hypercoagulable state, and endothelial dysfunction. The first one, stasis, basically talks about blood pooling in the veins. Okay, so any kind of situation or any kind of pathology that is going to cause blood to pool in the veins would predispose a patient to DVT. Example, you have a patient on admission. You are giving antibiotics because you are managing some form of disease. Let's say you are managing a cellulitis and the patient is diabetic and all. You have this patient on admission, and sometimes they tend to stay on admission for a very long time, 10 to 14 days, they'll be on admission. They'll be in bed and all that. Because they are in bed and they are not moving so much. 2 days ago, I talked about the fact that venous blood will tend to pool when you are sitting or you are lying at one side. Or I think that was yesterday, yeah. When you're sitting or lying at one side, because venous blood flow is not like arterial blood flow where the veins in terms of arteries tend to have like a thicker muscle layer to be able to push and then pump blood into systemic circulation. The veins don't have that kind of thick muscle layer. So you tend to have blood staying in the veins. And when you don't put some force on this blood, venous return or the blood pushing up into circulation is basically reduced. And that's why veins tend to have what we call valves, so that when you walk and then your pump action of the gastrocnemius and the soleus is set in motion, it can squeeze on these veins. It squeezes on the veins and then it pushes the blood up. The presence of the valves in the vein will prevent a backflow of the blood. And in this case, it will prevent what's pooling and then stasis of blood in the vein. So if you have any medical condition that is going to predispose you to pooling of blood in the venous circulation, in this case, the deep veins, for a very long time, then you're at risk of developing a DVT. This patient on admission, because the patient is going to be bedridden, going to be lying at one place for a long time, that in itself is stasis. So blood stays at one place and then there's a risk of the blood clotting. And that's why it's very, very necessary to put your patient on anticoagulation once they are going to stay on admission for some time. Okay. The next thing we'll look at is endothelial dysfunction. What is endothelial dysfunction? Endothelial dysfunction basically means that the inner lining of the deep veins have become damaged. Okay, so when the inner lining of the deep veins become damaged, we say that there's some form of dysfunction. And as I said, for a clot to form, even external clot to form, you expect that there's some sort of wound, there's a bleed, and then coagulation cascade will be set in motion. Then you have a clot or a patch forming over the wound to stop the bleeding. Thing is, when you go into the deep vessels, especially the deep vein, you can have damage to the intima of the deep veins. And there are medical conditions that can predispose you, or risk factors that can predispose you to endothelial dysfunction. Okay. Sometimes when you have some sort of vasculitis or inflammation of the blood vessel through an autoimmune condition, the dysfunction can be, or the damage can be extensive, that it can destroy the inner lining of the blood vessel. And once this is damaged, your body would form a clot to try and seal off the bleeding. Mind you, blood vessels also have blood supply. Okay. So every blood vessel you see also has tiny, tiny blood vessels inside that big blood vessel you are seeing to supply the big blood vessel to enable it work. So once you have a damage of the inner lining, the small blood vessels of that big blood vessel will tend to bleed. And once it bleeds, you need to have the clotting cascade being activated to form a clot. And as I said, once the clot is formed, it can trap red blood cells. You can have excess platelets, red blood cell, and then you tend to form what? A thrombus. Okay, so that's endothelial dysfunction. One main risk factor of endothelial dysfunction is smoking. Once you smoke, the nicotine in the smoke has the ability to destroy the inner lining of the blood vessel. And once this is destroyed, you end up forming a clot. The third component of the Beckhoff's triad is the hypercoagulable state. Some people naturally have certain medical conditions that cause them to clot faster than usual. Sometimes they are just there. They don't even have any massive injury. Slightest injury, the system starts clotting, and then they end up forming a blood clot. The coagulation cascade, or when you look at clotting, you look at it from two sides, okay? You look at it from the side where you have clotting factors, which would help your blood clot. And then once your blood clots, there's also, in quotes, anti-clotting factors, which prevent you from forming excessive clots. So the body is made in such a way that once the clotting cascade is activated, there's also something else that is also activated to regulate the kind of clot you form. Otherwise, once your blood starts clotting, everything would clot. But then naturally, the body is made in such a way that you don't have that happening. So once your blood starts clotting quickly, the anti-coagulation cascade also comes in. The body has certain enzymes and certain proteins that would come in to regulate the clotting. An example of this is there's something called antithrombin. And if you remember clotting factors, there's one called thrombin. So antithrombin, as the name suggests, will do the opposite of thrombin. So usually once you have the coagulation cascade being set in motion, antithrombin would also be working slightly in the background to regulate the clots that you form so that you don't form excess clot. There's also a substance called protein C and protein S. And these are also anticoagulation factors, which basically comes in to prevent you from forming what? Excess clot. Let's take two scenarios. Scenario one, you have excess clotting factors. So you end up forming a lot of clots. And then scenario two, you have a deficient anti-clotting factor system. So you are unable to control the clot that is being formed. So in the end, you still end up forming excess clot. Once you have this, we say you have what we call hypercoagulable state. So hypercoagulable state goes in two ways. The first way is you have excess clotting factors. Example, some patients have excess clotting factor 1, which is fibrinogen. Some people have more fibrinogen. So we say they have hyperfibrinogenemia. This patient who has hyperfibrinogenemia will end up forming more clots than a patient who has normal fibrinogen. Okay, so in this case, the patient has what? Hypercoagulable state. Some patients have less antithrombin. So when the clot is being formed, they don't have enough antithrombin to control the clot that is formed. So they end up having excess clot formation. The medical condition is called antithrombin deficiency. Okay, so it goes in two ways. It's either you have more clotting factors, which is causing your blood to clot faster, or you have less anti-clotting factors, and hence you are unable to control the clot that is being formed. Okay. Any questions on the pathophysiology aspect of the three things we've talked about before I proceed? The main thing is the pathophysiology. Once you get to understand it, managing the patients becomes easier. Okay, so the first one is, yeah.
Sir, some of us, we just joined, so it's like we are lost.
Don't be lost. Afterwards, we'll try and then would summarize everything. So don't be lost. I'm sure the lecture would drop in 10 minutes, and once it drops in 10 minutes, I'll put up another link and then we'll quickly join and then finish up. Okay. So we'll try and summarize afterwards. So basically all that I've said is that we are talking about deep venous thrombosis, and basically it's just about a thrombus forming in the deep veins. Okay, and I'm saying that thrombus in the layman's term is what? A clot. Usually you need some things to happen before this clot will form, and that is what brought us to the pathophysiology. And we said there are three things: stasis, endothelial dysfunction, and then a hypercoagulable state. I said stasis usually means that staying at one place for quite some time, as the name suggests. So you are traveling to America from Ghana, and then you are not transiting. You sit in the plane for so many hours. That is stasis, because basically you have excess blood pooling in the deep veins. And once you have this, there's a risk of clot forming, because we said that the veins don't have the muscle that will push blood up. So for a vein to work, we need you to be walking so that your pump action in the muscles in your calf area will squeeze the veins and then move up. But once you are sitting or sleeping at one place for a very long time, then you are bound to have what? Stasis or venous pooling, okay, of the blood. Then the next one we said, when you have damage in the blood vessel, just like having damage anywhere, your body needs to form a clot. And the formation of this clots would predispose you to forming a thrombus, okay? And then the last one, we said hypercoagulable state. And I said there are two ways to this. Way one means that you have excess clotting factors. So when you have the slightest injury, you start clotting excessively. And then the other way is that once you are clotting, your body produces some things to control the clot so that you don't produce excess clot. Okay, and these are anti-clotting factors. And I gave an example as antithrombin is one, protein C and protein S is one. So if you have less amounts of antithrombin, less amounts of protein C and protein S, then you are unable to control the clots that is being formed, and hence you have excess clots forming and you are in trouble, okay? So the risk factors, so as the name suggests, anything that is going to, one, cause stasis, two, cause a damage to the inner lining of the blood vessel, or three, predispose you to forming or the formation of clots excessively becomes a risk factor. So when you look at the slide, you can see prolonged immobility. Clearly, once you lie at one place for a very long time, maybe after some severe surgery, maybe after some accident, you have a fracture, you are in bed very long time. Because of the immobility, there's stasis. So there's a risk factor over there, okay? Most people who would have prolonged immobility will also tend to have some sort of endothelial dysfunction, as in you have a patient who's got a fracture and then you are managing the fracture and all that. The fracture in itself can cause an injury to the deep veins. That alone in itself is one risk factor of what's forming a clot. Now, after you manage this fracture, maybe you put in an iron nail or a cast or something, and the patient is going to lie in bed. The immobility will also put the patient at risk. So this patient is clearly at risk of developing a clot in the deep veins. Obesity comes with what? Lack of mobility. Once someone is obese, usually they sit at one place, they don't move so much. So there's a risk factor there. Okay. The next thing there is smoking, which I said will destroy the lining of the endothelium, okay, of the veins. And once that happens, you will be in trouble. So major surgeries, abdominal surgeries, orthopedic surgeries, during this surgery, we as clinicians might end up damaging or going through some vessels, and we'll repair the vessels. This puts you at risk of developing a clot. And after the surgery, you are going to be in bed, and sometimes we say don't move. You're going to stay in bed for quite some time, depending on the extent of the surgery. Put you at risk of stasis, and you can develop a clot. Patients who have cancers produce certain substances which tend to cause your blood to clot faster. They call these substances procoagulants. Some cancers produce procoagulants. So once you have a malignancy which is producing a procoagulant, the risk of you developing a clot is high. Then there's also pregnancy, which comes with a risk of developing a clot. When you use any medication that contains excess estrogen or estrogen, there's also a risk of developing a clot, like oral contraceptive pills, the combined ones, you can develop a clot. And people who have clotting disorders because they have excess amount of clotting factors or deficient amount of anti-clotting factors are also at risk of developing DVT. Okay, so there's a table I projected when you look at your slide. It's called the Wells criteria. We don't expect you to memorize this. What we need you to know about this is it's a criteria that we use to score the probability of DVT. So when you take a look at it, you can see that there are some parameters there, and then there's a score there. Okay, when you add all, there's a total score of 8. The last parameter you see there is when you take a look at someone who has a unilateral leg swelling and you don't think this is likely to be DVT, the score over there is -2. Okay, so once you are looking at it, If there's an active cancer, you give a score of 1. If the patient has some paralysis, a score of 1. A recently bedridden patient, a score of 1. When you look at the side and you realize that it's very tender, you give a score of 1. If it's swollen, a score of 1. Sometimes you measure the calf and then you compare it to the other calf. If it's more than 3 centimeters, a score of 1. Basically, what we are doing is we want to check to see if what you have is likely to be DVT. So it's just a criteria which you can always check your phone and then give the score. And we say that when you have, afterwards, when you add everything and you have a wall score greater than 2 or 2 or more, we say you have a positive wall score. It means it is likely that this is a DVT. If you have a wall score which is less than 2, then we say it's a negative wall score. It means it's not likely that it is a DVT. Okay, so wall score, you don't need to memorize it, but just know that it contains parameters, and these parameters, we give you values of 1 for each. So when you find these parameters in the patient, you just add all up. If afterwards you have a value of 2 and above, you say, oh, you are likely to have a DVT. If you have a value below 2, then it means that this is not likely to be DVT. For example, you see a patient who has calf swelling greater than 3 centimeters compared to the other leg, you give a value of 1. The patient also has pitting edema, you give a value of 1. Then you look at it and you say, oh, this patient is diabetic, there's a total temperature, WBC is high, all those things. I think this is a cellulitis. So you think the alternate diagnosis is more likely. So it becomes -2. So this patient will have +2 -2, which is 0. So then you say, oh, the patient has a negative wall score. The thing is that the fact that a patient has a negative wall score doesn't mean that the patient doesn't have DVT. That is what we should know. The wall score is just a clinical calculation that we do in our consulting rooms before we send the patient out to go and do the investigation. So if you think a patient has a negative wall score, it doesn't mean you will investigate for DVT. Okay. So I think for now, let me just end here, send another slide in and another link in so that we join, and then we can continue from clinical features and then finish. Okay. So I'll see you guys soon.
Okay.
All right.